Wish to welcome you to this yet another session on our topographic anatomy series of the lower limb. In this particular session, we are going to look at the topographic anatomy of the leg. Just to give you a clue of where we are, so we are in the process of doing a series on topographic anatomy of the lower limb, and for the sake of delivery, I've chosen to do this in different parts, and now we are doing the leg. You can see we've already done the first four there as one, and now we're doing the fifth one there. The last two are yet to be done. Just a reminder is that the lower limb has multiple segments. You have the gluteal region, thigh, leg, and foot. And in this session, we are focusing on the leg, which is the segment from the knee to the ankle joint. Our internal learning outcome are brief. One is basically to look at the relevant osteology. And in this part, we are going to focus on the tibia bone as well as the fibula bone. Those are the bones of the leg, and we look at their parts and important aspects. While we are still there, we're also going to highlight on the key anatomical landmarks in the leg, bearing in mind that most of these landmarks are actually bony landmarks. The other thing that we are going to look at would be to describe the subcutaneous structures of the leg. In this particular objective, we'll focus mainly on this cutaneous innervation of the leg, as well as the superficial veins in the leg. The superficial veins in the leg have, however, been mentioned in another lecture, so this will just be brief. We'll then go deeper and look at the organization of the fascia cruris. The fascia cruris is the deep fascia of the leg, just like the way fascia lata is the deep fascia of the thigh. So we look at the organization of the fascia cruris, and while we're still there, we'll explain how the three osteofascial compartments of the leg are formed. Maybe just to mention that the leg has three osteofascial compartments formed by extensions of the fascia cruris, and we're going to see how that actually happens. Each osteofascial compartment will definitely have muscular components as well as neurovascular structures. We will mention the neurovascular structures in each compartment. We'll also discuss the muscle groups that are in each compartment. And for these muscles, we'll look at their actions. We may not be able to look at the origin and insertion of each of the muscles. I think that's more at personal level. You can do that at your own time. It's not very relevant to do that in a lecture session, but the major concepts are the ones that will be highlighted in this session. We'll also talk about those neurovascular structures which are found in those compartments, but we look at them not from a compartment perspective, but from the nerves and the vessels perspective. Yes, so that will be the outline. We can begin with the first one, which is the relevant osteology. Here we are going to look at two bones, tibia and fibula, and the bone projected there is actually tibia. So we can conclude actually that this is the left tibia. One of the things that we expect you to know is to be able to cite the bone tibia. Why am I saying this is left tibia? We know that this is the anterior part, and so the part we're not seeing is posterior. We also know that this is the proximal part, so this is the distal part, and because of this projection, we know that this is the medial side, which makes the other side be the lateral side. So this looks like the tibia of a person standing in front of me, and so this will be their left. Now, Tibia is the bone that lies medial on the leg. That means that the fibula lies laterally. One important thing about tibia is that it has a surface, this surface, that is predominantly subcutaneous. And you can feel that even on yourself. You can feel this medial surface very subcutaneous. You can also feel the anterior border there, very subcutaneous. So it's predominantly subcutaneous. And that has implications actually on the blood supply and the healing process of this bone in case it's fractured. The proximal part is expanded. That expanded part of the tibia is the part that will participate in the knee articulation. And there are a number of things that we know there. So one is this part here, which is the tibia tuberosity. You'll remember that tibia tuberosity is a point of attachment of the patellar tendon, which is the extension of the quadriceps femoris unit. And so this is the point of action of the quadriceps femoris. Patellar tendon is also called the ligamentum patella. And associated with it are two bursae. Remember, there's the subcutaneous infrapatellar bursa and the deep infrapatellar bursa. You'll remember that the subcutaneous infrapatellar bursa is the one that is usually called the clergyman's knee when it is inflamed. So this still shows you the tibia tuberosity, which is somewhere there. Other than the tibia tuberosity, we also have the condyles of tibia. So the tibial condyles, the medial and the lateral tibial condyles, the ones that participate in tibiofemoral articulation, which we call the knee joint. And the anatomy of the medial and lateral tibial condyles have already been handled when we're discussing the knee joint anatomy. So it will be important to just be able to know the differences between the medial and the lateral tibial condyles. That is particularly important because we can still give you a view of the proximal tibia and expect it to be able to side that bone based on the morphological differences of the two tibial condyles when you look at it from a bird's eye view. The intercondylar area is that zone between the medial and the lateral condyle, and in that intercondylar area, we do have an elevated region that we call the intercondylar eminence, together with the anterior and the posterior intercondylar areas. And on the eminence, we have some projections that we call the tubercles. So we have the lateral intercondylar tubercle and the medial intercondylar tubercle. So that would be the proximal tibia, very expanded, as we can see, to form part of the knee joint complex. Moving down to the shafts, the shaft of tibia is generally triangular in cross-section with three surfaces. So there's the medial surface, which is this one. We have the lateral surface, which is that one, and the posterior surface, which is that one. Anteriorly, we talk of a border. So there's a border that separates the medial and the lateral surfaces of tibia. Maybe this is the anterior border, we can see it there nicely. And so this is the medial, and that's the lateral surface. The medial surface, the one that is predominantly subcutaneous. As you can see, the bone is much expanded proximally and slightly expanded also distally. So the narrowest part of the bone is somewhere there. Important to note is that the inferior projection of the tibia, this one here, it projects medially. That medial inferior projection of the tibia is what we call the medial malleolus. And so we can use that actually to be able to also side tibia, knowing that the medial malleolus is a medial projection on the distal aspect of the bone. That medial malleolus forms part of the ankle articulation. So this is the medial malleolus and that region there, which also articulates with the tarsal bones, particularly talus. That's what we call the tibial plafond. So this is the tibial plafond, and that's the medial malleolus. Those contribute to the talocrural articulation, or basically the ankle joint proper. Now, something important about the blood supply to tibia, I'd mentioned it earlier, but I want to clarify with detail now. Just like any other long bone, tibia has three standard sources of blood supply. There are those arteries that enter at the metaphysis of the bone. The arteries that enter the metaphysis of a long bone are arteries that arise from the anastomosis around the capsule of the joint related to that region. You'll remember that long bones will most likely be having synovial joint, joining them with other bones. And so because the synovial joint, there'll be a capsule, and around this capsule, there'll be anastomosis of arteries. From this anastomosis of arteries, there'll be some vessels that follow the connective tissue profile of the capsule to enter into the bone. And we call these metaphyseal arteries. In some quarters, we may have called them retinacular arteries. And so we have several metaphyseal arteries that enter at the metaphysis. And these small holes around that region demonstrate the reality of the presence of metaphyseal arteries. So that those ones. One thing to note about tibia is that because the proximal part is expanded and of course the bigger joint, then most metaphyseal arteries will be proximal. Yes, there are a few metaphyseal arteries that are also distal related to the ankle articulation, which means that we also have some metaphyseal arteries that are around the ankle joint, part of the ankle anastomosis. And so those arteries also enter the bone through those small holes we see on the distal tibia. So we have metaphyseal arteries, and that concept of metaphyseal arteries is not limited to tibia. Even fibula, because a long bone, will also have metaphyseal arteries on its both ends. So proximal end as well as the distal end will still have metaphyseal arteries. You can call them retinacular arteries. The second source of blood supply to tibia and any other long bone is the presence of a diaphyseal artery. The diaphyseal artery is an artery that supplies the shaft of the long bone. Now for tibia, that diaphyseal artery is usually a branch of the posterior tibial artery, can be a branch of the peroneal artery as well. So basically the vessel enters through a Newton foramen that is usually located around this region, mainly on the proximal parts of the shaft. And that's again important, that the Newton artery, the diaphyseal artery of tibia, enter the shaft mainly on its proximal parts as opposed to its distal parts. Similar concept will apply to fibula, usually a branch from the peroneal artery that supplies the shaft of fibula and will have Newton artery. But now that's not necessarily very high up, could be somewhere in the middle as well. And then we have the periosteal arteries. The periosteal arteries are arteries that enter the bone through the periosteum. And this is related to muscle attachments to the bone. So basically, the vessel that supply the muscle will also sleeve through the periosteum and supply the bone. And that becomes very significant for any bone that has a lot of muscular attachment. Like fibula, it has muscle attachment in most of its shaft. And that means that fibula, therefore, is well vascularized with the periosteal arteries because these ones are through muscle attachment. That is not the same story that applies to tibia. Tibia has muscle attachment which are predominantly on its proximal end and very scarce in its distal end. The distal part of tibia is largely related to tendons as opposed to fleshy muscle components. Now, because of that, the periosteal arteries to tibia are predominantly proximal. And so the distal part of tibia has scarce of the periosteal arteries, if any. So what is the implication of this story? All that we've said is that the proximal tibia receives good blood supply, but the distal tibia does not receive very good blood supply. The clinical implication of this is that if tibia is fractured, then that fracture will take a longer time to heal. It's one of the bones that will take very long to heal compared to any other bone. And usually for two main reasons. One is that the distal tibia is poorly vascularized, and so there'll be delayed healing. Femur would heal much faster than tibia. Fibula will heal much faster than tibia for that particular reason. Now, the other reason why maybe tibia, and especially distal tibial fractures, will also take longer to heal is because of the fact that you say that tibia is predominantly subcutaneous. That means that if it does a fracture, then most likely this fracture is going to be communicating with the skin to the atmosphere, and we call that compound fracture. Compound fracture, those fractures that communicate with the skin, and there's now a wound on the outside externally. Compound fractures will also take time to heal because of chances of infections being common. So tibia is one of those bones that again tend to get compound fractures because of the fact that it's subcutaneous. And then another concept that's clinical that you also mentioned is that tibial fractures take a long time to heal because of poor blood supply, especially its distal part. And I've given you reasons why the distal part has poor blood supply. Now let's talk about fibula. Fibula bone lies lateral to tibia, and it's also slender, as we can see. And important to note as a diversion, however, is that the articulation between tibia and fibula are on three parts. We call them tibiofibular articulations. There are actually three. Well, we can conventionally talk about two, but there's a third one that we can see. So let's talk about them. The proximal tibiofibular joint, this one here, is a synovial planar joint. This synovial planar joint means that it has a capsule. It's a synovial joint as a capsule, and it allows some mobility because it's synovial. Remember, this joint, the proximal tibiofibular joint, may communicate with the knee joint. And that is why some people may consider it part of the knee joint complex. In our discussions, we did not quite include it as part of the knee joint, and I'm referring to our previous discussion on the knee joint. But it's important to just note that some authorities consider it part of the knee joint because of that proximity to the femoral articulation, and also because of the fact that sometimes the synovial joint space actually communicates. There's some ligaments that are actually shared between the two joints. So that is the proximal tibiofibular articulation. It is a synovial planar joint. Then we have the distal tibiofibular articulation. The distal tibiofibular articulation has a unique name. We call it the distal lower extremity syndesmosis. That tells you that it's a syndesmotic type of joint. Remember, a syndesmosis is a type of a joint where the articulating bones are joined by a ligament, and usually a strong ligament for that part most of the time. So this is the distal lower extremity syndesmosis, the distal tibiofibular joint. It consists of anterior and posterior tibiofibular ligaments, not shown in these particular images, but take note that this is the joint. And this distal tibiofibular joint, or the DLES, distal lower extremity syndesmosis, is one most important factor in maintaining the stability of the ankle joint. The presence of that joint makes us form a very nice cave here that we call the mortise of the ankle joint. And so with this medial malleolus being present and tibial plafond being there, and this projection of the fibula called lateral malleolus, that fork-like structure is what we call the mortise of the ankle joint. The integrity of the mortise relies on the integrity of the syndesmosis we're talking about. And so the most important stability factor of the ankle joint articulation. Now, I mentioned that we may have a third joint, and I know you're wondering which one is this. So anyway, the middle part, the shafts of the two bones are joined by interosseous membrane. We can still consider that as part of a joint, mostly syndesmotic type of a joint as well. So the interosseous membrane is this connective tissue membrane that join the two bones. Important to note that it has some gaps. There's a gap on its upper end. The gap on its upper end is not a gap through it. It's a gap above it. And that gap allows the passage of the anterior tibial vessels. Remember that popliteal artery comes like this and bifurcates into two as it terminates. The posterior tibial artery that goes down and the anterior tibial artery that goes through that gap to run in the anterior aspect of the interosseous membrane. So this gap is for the passage of the anterior tibial vessels. Remember, the artery goes above as opposed to through the interosseous membrane. And once the artery goes above, it will go to the anterior aspect of the leg, and that's why they are called the anterior tibial vessels. And the one that remains behind is then correctly called the posterior tibial vessels. This other gap down here is also for passage of another vessel. The vessel that passes there is actually the peroneal artery. So the peroneal artery termination may many times just go through that opening to become anterior as well, usually joining the anterior tibial artery. The peroneal artery is a branch of posterior tibial, as given somewhere between around that region. So that peroneal artery will be running somewhere here, and then when it reaches there, its terminal branch may actually just go through that gap that you're seeing and become anterior. And so when it becomes anterior, it pops through here and it augments the territory of the anterior tibial tree. At this point, then, will be called the dorsalis pedis artery. Okay, so that was just to elaborate on the tibiofibular articulations, but focusing on the fibula. So the fibula bone is largely for two major functions. One is the stability of the ankle joint, as I've already mentioned, that the lateral malleolus of the fibula contribute to the stability of the ankle. But the other key role of the fibula is muscle attachment. It's a bone there that has multiple muscles attached to it. So it's largely for muscular attachment. So it has a minimal role in weight bearing. The bone that bears weight is predominantly the tibia. And that's why I'm saying that the major functions of fibula is muscle attachment and stability and less of weight bearing. The bone has the following key parts that are worth mentioning. So the head of fibula is the proximal part that is expanded. This proximal part, remember, forms the insertion or the attachment of some key structures. For example, the fibular collateral ligament of the knee attaches on it there. We also have the biceps femoris tendon. The tendon of biceps femoris also attaches on the head there. And perhaps those are the two that I really want you to remember are the structures that attach on the head of fibula. Of course, there could be other ligaments as well, but for the sake of keeping it simple and clear and keeping to most important things, I want to leave it to those two. Below the head of fibula is that narrow region that we call the neck of fibula. Fibular neck is clinically important because around this point is where the common peroneal nerve turns. So common peroneal nerve comes like this and winds around here on that lateral aspect, not middle aspect, but lateral aspect there. So the common peroneal nerve winds around perhaps the head and neck of fibular bone. And that becomes a very important surface landmark for the common peroneal nerve, the fibular head and neck. It's also the site that the nerve is most prone to injury because that nerve is now subcutaneous at that point and is against an osseous structure. So it's prone to compression at that point. We have the shaft of fibula, which is very long with several morphological variants. The shaft may not be very standard in terms of its description, but it has borders as well and surfaces. Importantly, on the lower part of fibula is this projection inferiorly that we call the lateral malleolus. The lateral malleolus is a projection of the fibula and it contributes to the stability of the ankle, as I already mentioned. On this lateral malleolus, there'll be some attachments as well that are worth mentioning. So importantly is the calcaneofibular ligament. The calcaneofibular ligament touches here on that lower tip of the bone, and it's an important ligament in the ankle stability. We also have talofibular ligaments that also attach onto the malleoli. So we have the anterior and posterior talofibular ligaments that attach onto the malleoli. One important thing to note about fibula is the malleola has a depression on its posterior-medial aspect that we call the malleolar fossa. So we can use the malleolar fossa as well to be able to side the fibula. Why? Because we are saying this depression, that fossa, is on the malleolus, which means on the distal part. And we're also saying it's on the medial aspect of the malleolus. So the fossa is on this side and not that side. So we can use that to be able to orient the bone in its transverse axis, the medial lateral axis. Then we're also saying that that fossa is more posterior than anterior. So again, we can still use the fossa to orient the bone in its anterior-posterior axis. One structure we are using to orient the bone in its three axes: superior-inferior axis, medial lateral axis, anterior-posterior axis. And what else do you need to side a bone? You just need to side a bone in those three axes, and you're able to decide whether this bone is a right or a left bone. So with that understanding, the malleolar fossa can be used to side fibula. Conventionally, then we can actually hide the whole bone and just leave you with the lateral malleolus and ask you to side that fibula. And then we still expect to do that based on this particular simple knowledge. Great. So these are the different fibula, and maybe this particular one is one I want to choose to demonstrate for you the malleolar fossa. So this is the lateral malleolus, and this is the part that articulate with the talus, the tibio-fibula, distal tibio-fibula joint is somewhere here, but this part articulates the talus. Now that's the malleolar fossa there, that depression. So now that this depression, we can see it on the inferior part, medial aspect, and posterior, this particular fibula, we can actually conclude is of the right side. Compare with this one, where this is the part that articulates the talus, and this is the malleolar fossa. So this one we can actually conclude that is the left talus, sorry, the left fibula. Now, one thing that some people also use, which is simple, but you need to understand the basis, is just try to hold this bone with its malleolus using your thumb as the one that actually hold the bone. And you'll realize that the left one will be easy to hold with the left thumb or the left hand, and the right one will be easy to hold with the right hand. So for example, this one, I've told you this is left fibula. So you put your 4 fingers below and then your left thumb on the fossa there. Very easy to hold. And for this one, it will be easy to hold it with your right because the right. So again, four fingers below the lateral malleolus, then your right thumb onto that fossa to stabilize it. So if you find that you are struggling to hold this with your left hand, then you know that's definitely not left. But if you find it easy to hold it with your left hand, then you know that's actually left. That's the concept. Well, you need to understand the logic behind it, but that's a simple way of just distinguishing right and left fibula. Okay, now let's describe the subcutaneous structures in the leg. We'd already talked about this when you're looking at anatomy of the thigh. So I'll just focus on the leg region, starting the cutaneous innervation of the leg. So medial aspects of the leg will be predominantly by the saphenous nerve. You'll remember that saphenous nerve is a terminal branch of the femoral nerve. This nerve is responsible for cutaneous innervation of the medial side of the leg, as well as the medial side, medial aspect of the foot. So it's a very long nerve. The other nerve is the cirral nerve. So cirral nerve is formed by union of two nerves. The medial cirral being a branch of the tibial nerve, and the lateral cirral, which is also called cirral communicating, being a branch of the common peroneal nerve. The cirral nerve is initially posterior, so it supplies a posterior cuff there. But moving down, it goes laterally, and so supplies the lateral aspect of the ankle, and also goes to supply the skin of the lateral margin of the foot. So that's cirral nerve. So remember, the main cirral nerve, which is also called the medial cirral nerve, is a branch of tibial nerve. Then cirral communicating nerve, which is also called lateral cirral nerve, is a branch of common peroneal. And the two contribute to innervation of the posterior calf, as well as the innervation of the posterolateral ankle and the lateral margin of the foot. We also have the lateral cutaneous nerve of the calf. Lateral cutaneous nerve of the calf is a branch of the common peroneal nerve, and it's responsible for innervation of the posterolateral calf, especially on its upper part. So the proximal parts of the posterolateral calf are supplied by the lateral cutaneous nerve of the calf. The posterior cutaneous nerve of the thigh is known to terminate largely in the skin over the popliteal fossa. However, occasionally it may extend a bit to also supply the skin of the upper part of the posterior calf. May a bit. Moving down, we have what we call the superficial peroneal nerve. Superficial peroneal nerve is a branch of the deep peroneal nerve. Sorry, it's a branch of the common peroneal nerve. So common peroneal nerve divides into superficial and deep peroneal nerves. The superficial peroneal nerve runs in the lateral compartment of the leg, but pierces the deep fascia at the junction between the middle 1/3 and the distal 1/3 of the leg. So somewhere there it pierces the deep fascia and becomes subcutaneous. Therefore, supplying the skin, that inverted V on the anterolateral aspect of the distal leg, but mainly those nerves branching and supplying the skin over the top dorsum of the foot. So it's a nerve that supplies the skin of the top dorsum of the foot. Remember that sural is on the lateral aspect and saphenous nerve is on the middle aspect. So the top dorsum here, much of that skin is supplied by the superficial peroneal nerve. The deep peroneal nerve, worth mentioning now that talked about the skin innervation of the leg and foot as well, especially dorsum. It's important to note that the deep peroneal nerve, which is also a terminal branch of the common peroneal nerve, is predominantly deep, as the name suggests, but it still has a cutaneous distribution. The cutaneous distribution of that nerve is the skin of the first web space. And commonly, that's where we'll test its cutaneous distribution in a clinical setting. Great. So that is the innervation, sensory innervation of the skin of the leg. I've also talked about sensory innervation, the skin of the dorsum of the foot. The skin of the plantars of the foot will be supplied by branches of tibial nerve, and we'll talk about that as the lecture goes on. I would encourage you to familiarize with the various dermatomes of the leg, and not just leg anyway, the entire lower limb, And we've seen this image again several times. There's no shorter formula of remembering this. The more you see it, the more it will sink. But it's important to understand the dermatomal anatomy of the body, because this helps us to pick some clinical aspects, especially when you want to determine some segments of nerve injury or disease. How about superficial veins of the leg? So superficial veins of the leg will not necessarily be unique to the leg because they extend to maybe just the whole of lower limb. And we've talked about superficial veins of the lower limb. We mentioned that superficial venous system of the lower limb is predominantly the saphenous venous system, where we have the great saphenous venous system on the medial aspect and the small saphenous venous system on the lateral aspect. So just to remember that the great saphenous vein begins from the union of the medial marginal vein and the medial aspect of the dorsovenous arc. And so that great saphenous vein will run on the middle aspect of the foot and then pass anterior to the medial malleolus and run on the middle aspect of the leg. Then we'll pass on the posterior middle aspect of the knee and go upwards. Some of its key landmarks would be the medial malleolus of the around the ankle region, as well as posterior middle side of the knee joint. The small saphenous vein begin by union of the lateral marginal vein and the lateral aspect of the dorsovenous arc. The small saphenous vein runs on the lateral margin of the foot. It will pass behind lateral malleolus, and this vein goes posteriorly and superiorly, ascending all the way and piercing the deep fascia, the popliteal fossa, so that it can drain into the popliteal vein. The other small veins which are on the foot are predominantly not named, and they'll either join the great saphenous or the small saphenous vein. So I'll leave it there for the superficial veins. I think that's very repetitive because we've talked about this several times in the previous sessions. Now we can talk about the organization of the fascia cruris. So the fascia cruris is the deep fascia of the leg, just like fascia lata is the deep fascia of the thigh. Indeed, the fascia cruris is actually a continuation of the fascia lata. So it continues as fascia cruris. Fascia lata continues fascia cruris, especially in parts where the fascia is attached. But where the fascia is attached, so we know that's attached to the margins of the patella, both medial margin as well as lateral margin of the patella. We have the fascia cruris being attached there. It's also attached to the patellar tendon itself. So beyond the patella, remember we have the tendon. So it was attached to the patellar tendon, both on the medial and lateral aspects of the tendon. The fascia is also attached to the tibial tuberosity as well as the tibial condyle. So we'll remember that tibial tuberosity will be somewhere here. And then tibial condyles will also be somewhere there and there. This fascia is attached to it. It's attached to the head of fibula as well. That would be somewhere around there. And predominantly also attaches to the periosteum of the tibial shaft. Why? Because I mentioned that tibia is subcutaneous. And so fascia cruris actually attaches onto the tibia predominantly, and that would be largely on the anterior margin of tibia, almost throughout the bone. There's some modifications that fascia cruris has that I want to mention. So distally here, around the ankle joint, fascia cruris has some thickening that cross the ankle joint. This thickening are supposed to hold in place the tendons and neurovascular structures that traverse the ankle. We call them the retinaculi. So on the anterior aspect of the ankle, we have the extensor retinaculum. There are two extensor retinaculum. The inferior extensor retinaculum, this one, is Y-shaped, and the superior extensor retinaculum there is not Y-shaped, but tend to be also very broad, however. So this is the superior extensor retinaculum, and this is the inferior extensor retinaculum that is Y-shaped. This retinacula hold the anterior tendons and neurovascular structures around the ankle so that they do not bowstring. This shows you the retinaculum beta, the superior as well as the inferior one. We also have the flexor retinaculum. The flexor retinaculum is on the posterior-medial aspect of the ankle. This retinaculum arising from the medial malleolus to the calcaneus. So that's the band we are calling the flexor retinaculum, again holding the tendons and neurovascular structures in place. The tendons and neurovascular structures here would be the ones in the posterior compartment. Other than that, we also have the anterior and posterior crural intermuscular septae. So this is best demonstrated in cross section. So this is fibula, that's tibia. We have this is as the intermuscular septum arising from the fascia cruris. So we can see this is a fascia cruris, and so this is the anterior intermuscular septum of the leg, and this is the posterior intermuscular septum of the leg. Both anterior and posterior intermuscular septae attach to the fibula, but they arise from the fascia cruris, or you can look at it the other way around, arise from the fibula and insert into the fascia cruris. Either way, they're all attachments. This anterior and posterior intermuscular septa are useful in dividing the leg into its various osteofascial compartments. The deep transverse fascia, which is also known as the transverse intermuscular septum of the leg, is also a modification of the fascia cruris. This is the deep transverse fascia of the leg. This deep transverse fascia divides the posterior muscle group into a deep and a superficial group. Again, as you can see, still attached to the fascia cruris. Now, these attachments are worth noting so that if somebody is going to manage surgically compartment syndromes of the leg, then you know where to make the incision that is appropriate to relieve a particular compartment. So for example, if you are to relieve posterior compartment syndrome that is deep, then you know that your option can only be that point of incision to relieve pressure here. If you want to relieve pressure from either this or this with a common incision, then maybe making the incision here would be better so that you make that one there and one there. So they are important in informing where incisions are made in the management of compartment syndromes. I'll talk about compartment syndromes shortly. Great. So with that anatomy, we can now talk about how the three osteofascial compartments of the leg are formed. So first, what we've mentioned earlier is that tibia and fibula are joined by the interosseous membrane. The interosseous membrane that exists between the two bones help us to separate two compartments of the leg. The one in front termed the anterior compartment and the one behind termed posterior compartment. This image shows you a better view of that. So this is tibia in cross-section, that's fibula in cross-section, and this is the interosseous membrane. We take note that the compartment anterior to the membrane is anterior compartment, and the compartment behind the membrane is the posterior leg compartment. As simple as that. So the membrane is useful in separating the anterior and the posterior compartment. And as you can see, now on the anterior aspect, we can see the anterior tibial vessels there. In the posterior aspect, we can see the posterior tibial vessels. Then we have the anterior and posterior intermuscular septa that are attached to the fibula. So this is the anterior intermuscular septum. And that's the posterior intermuscular septum. Those two septa separate the peroneal compartment of the leg, or otherwise known as the lateral compartment of the leg, from the other two. So this is the lateral leg compartment. And this lateral leg compartment is separated from the anterior and posterior compartment by the corresponding crural intermuscular septae. So now we have anterior compartment, posterior compartment, and lateral compartment of the leg. The posterior compartment of the leg is further divided by the deep transverse septum, as I mentioned earlier. That's the deep transverse septum that divides the posterior compartment of the leg into two, the deep compartments and the superficial compartments of the posterior leg compartment. Great, so those are the divisions and compartments of the leg. I want us to now look at each of the compartments, talk about the structures found in each of the compartments, and especially the muscles, talking about the actions. Let's begin with the anterior leg compartment, labeled A there. So the anterior leg compartment is the compartment that is in front of the interosseous membrane of the leg. We can describe its boundaries. So posteriorly, we have the interosseous membrane. Medially, we have the lateral surface of tibia. And laterally, we have the anterior intermuscular septum of the leg. Of course, anterior, it's limited with the fascia cruris. So those are the boundaries of the anterior leg compartment. What does the anterior leg compartment contain? It contains this neurovascular bundle that lies anterior to the interosseous membrane, the deep peroneal nerve, and the anterior tibial vessels. The anterior tibial vessels, as I already mentioned, the anterior tibial artery is a direct branch of the popliteal artery that passes above the interosseous membrane to become anterior. This anterior tibial artery will supply the structures in the anterior leg compartment and go all the way down, cross the ankle joint anteriorly to become the dorsalis pedis artery. So the anterior tibial artery is the one that continues as the dorsalis pedis artery on the dorsum of the foot. Of course, along its path, it will be supplying various structures through multiple branches. Some of them are named, some of them may not be named. Most of these are muscular branches to the anterior compartment of the leg, as well as maybe what we can call tarsal branches and malleolar branches around the ankle joint. Then we have the deep peroneal nerve. Deep peroneal nerve is a branch of the common peroneal nerve. So the common peroneal nerve, after winding around the neck of fibula, terminates into two. The deep peroneal nerve that enters the anterior compartment and the superficial peroneal nerve that enters the lateral compartment. So this deep peroneal nerve that enters the anterior compartment provide motor innervation to the muscles of the anterior leg compartment. And then this nerve continues all the way to the dorsum of the foot as well. It also supplies a muscle in the dorsum of the foot before terminating as a sensory nerve in the first interdigital web space of the foot. Great. The other contents of the anterior leg compartment are basically the muscles. We call them the dorsiflexors because they cause dorsiflexion at the ankle joint. Some of them extend all the way to the toes to cause digital extension. And because of this action, therefore, the anterior leg compartment is termed the extensor compartment of the leg. Now, do not confuse the term extension by looking at the movement of the ankle joint because it may not be very conforming to what you know as extension. But generally speaking, morphologically, the way lower limb is organized is that dorsiflexion is the true extension, except because of the ambiguity of how the angle is changing. We do not like calling it extension of the ankle. We call it dorsiflexion at the ankle. So some of the tendons that cause dorsiflexion still continue to go to the toes and cause extension of the toes. When the toes go up, we call that extension of the toes. And so that's why this muscle group is called the extensor compartment of the leg. 4 muscles are found in this territory. So we have tibialis anterior muscle. We have the extensor hallucis longus. We have extensor digitorum longus. And we have the peroneus tertius muscle. In this image, you may just see 3 bellies because the muscle component that we are calling the peroneus tertius attaches much inferiorly. And when you cross, it is predominant tendon as well. So this image shows you what I've just told you. So this is the anterior leg compartment. Tibialis anterior is that. As you can see, the muscles are predominantly fleshy proximally, as I told you earlier, and less fleshy distally, making the distal tibia be less vascularized. So this is the tendon of tibialis anterior. That muscle causes dorsiflexion as well as inversion of the foot. This one is the extensor hallucis longus. Hallucis from the word hallux means the big toe. So it extends the big toe, but also causes dorsiflexion at the ankle. The third tendon there is the extensor digitorum longus. Extensor digitorum longus has a tendon that splits into 4, going to the 4 lateral toes. So we call that extensor digitorum longus. Peroneus tertius is actually attached to extensor digitorum longus, except that it's a bit fleshy up to down there. And then its tendon goes to that side. I'll show you in the next image better. Important to note is that these tendons, the dorsiflexors, are confined at the level of the ankle joint by the extensor retinaculum. However, these tendons continue all the way to the dorsum of the foot, as you can see here. Now, while we are still here, I may want to talk about what we call the anterior compartment syndrome. Out of all the three compartments, the anterior compartment is the one that tends to get what we call the compartment syndrome. What is a compartment syndrome? A compartment syndrome is the symptomatology that a patient experiences following raised intercompartment pressure that leads to compression of some structures within a compartment. Why is the leg more prone to this? Fascia cruris is a very tough fascia. And because of this, it is non-yielding, which means that if you have something that occupies extra space within the leg, then there'll be no space for expansion to accommodate that thing that is occupying extra space, because fascia cruris is non-yielding. Now, because it is non-yielding, it means that if there is something occupying it, for example, there's a bleed within the anterior compartment, it will just cause raised intracompartment pressure. When you raise pressure within an osteofascial compartment, several things will suffer. Among them will be the neurovascular structures. And so the symptomatology that patients get will be related to the fact that some structures have been compromised within the compartment. So let's think about that again, and maybe I take you to this image as we think about that. We are saying that fascia cruris is non-yielding. So if there is raised pressure here, or rather if there's something occupying extra space here, it could be a bleed, it could be a tumor, it could be inflammation, whatever, this fascia will not give way to expand. And so the pressure here will build up. Because of building pressure there, there'll be some symptoms. So let's think about the symptoms that are likely to happen. And I want you to think about them. One of them is that we are likely to experience a lot of pain. So pain, and let me call it excruciating pain, pain that does not respond even to common analgesics, is one of the clinical symptoms of compartment syndrome. Why is that so? Pain can be caused by a number of things. For example, if the pressure here is building, then we know that fascia cruris here, being attached to tibia, will be trying to peel off because of that pressure. That's an example of something that can actually cause pain along the anterior compartment. Many other things can cause pain, but that's just one of them. Okay, other than pain, what else could be there? The anterior tibial artery will be compressed. And if it's compressed, how will that manifest clinically? It will mean that it will now not be able to take blood all the way down to the dorsalis pedis artery properly. So clinically, if you are to feel the pulse of the anterior tibial artery, you'll not be able to feel that pulse, or it will be a very weak pulse. So we talk about absence or weakness of a distal pulse as another clinical manifestation of compartment syndrome. Pulselessness distally. Disappearance of the distal pulse. So remember, it has to be a distal pulse. You can't talk about absence of popliteal pulse and then talk about anterior leg compartment syndrome. No. The pulse must be a distal one and generally affected by that path. Again, if the pulse of the posterior tibial artery is the one that's disappeared, that cannot give you a clue to anterior compartment syndrome of the leg. It could be a posterior compartment syndrome, but not anterior compartment syndrome of the leg. So I've talked about pain, I've talked about pulselessness distally. The third thing is that if this blood and they're down properly, then we can talk about the fact that there'll be some level of pallor distally, that there'll be pallor. So pallor is another clinical sign of compartment syndrome. Now, where do we check the pallor? In this particular context, that can be a bit difficult, but as a general concept, pallor is a good thing to also check. Now, in this particular context, you need to check on how vascularized the dorsum of the foot is, and is it looking pale or not? So that would be a bit difficult to determine clinically, but as a general concept, you understand that pallor is something that can be checked. Now, what happens if you compress the nerves? Compression of the nerves, if they are motor nerves, it means that they'll now not be able to transmit impulses properly to the muscles they're innervating. And that means that those muscles be paralyzed. So there's some level of paralysis. And if the anterior muscles of the leg are paralyzed, how will that manifest? We've mentioned that these muscles are dorsiflexors and toe extensors. So if they're paralyzed, it means that we'll have weak dorsiflexion. And we'll also have weak toe extension. The foot will actually be appearing like it's in plantar flexion. Some form of foot drop we'll see. So that's paralysis. But also think about the sensory distribution of the deep peroneal nerve. We mentioned that the deep peroneal nerve has a sensory distribution in the first interdigital cleft. So if the rest within the anterior compartment, that will have clinical implication as well. The clinical implication that there'll be disturbed sensation, what we call paresthesia, disturbed sensation over the sensory distribution of this nerve, which is the first interdigital cleft. You can take that as a concept as well. If it was another compartment, there'll be another sensory territory that we'll be focusing on. But because we're talking about anterior compartment syndrome of the leg, then the sensory territory to check is the first interdigital cleft. Well, what I have narrated to you constitute what we call the compartment syndrome. Generally, some people use PIS to talk about the symptoms related to compartment syndrome. The main concept is for you to understand the basis. Why is there pain? Why is there pallor? Why is there pulselessness? Why is there paralysis? Why is there paresthesia? I've talked about some 5 P's of compartment syndrome. If this was another compartment, the concept of the P's will remain. The interpretation of the P's is what will vary. For example, if you talk about pallor, need to be pallor where. If you talk about pain, to be pain where. If you talk about paralysis of which muscles and how does that manifest morphologically. If you're talking about pulselessness, then it will be where. So it's more of the where that will change, but the concept remain. Overall, remember that the leg is a common site for compartment syndromes, and anterior leg compartment is the one that's most prone to compartment syndromes. So this image shows you the tendons that arise from the anterior leg compartment that cross the ankle joint. Here we see the inferior extensor retinaculum, Y-shaped, and the superior extensor retinaculum holding the tendons to prevent the bowstringing popping of the tendons. Tibialis anterior, extensor hallucis, extensor digitorum, and peroneus fascia. So in this image, we can see peroneus fascia nicely, the fleshy component there, and its tendon there, inserting into the base of the first metacarpal bone, metatarsal bone there, while extensor digitorum splitting into 4 tendons that go to the 4 toes actually. The muscle you're seeing deep to the tendons is now the extensor digitorum brevis that has 4 tendon slips as well. The tendon slips of the brevis now go onto the medial 4 toes, which means that the hallux also receive one of the 2 slips and then the other 3. So this small one does not usually receive a tendon slip from extensor digitorum brevis. That's one unique thing you need to know, so that we remember that extensor digitorum longus and extensor digitorum brevis do not necessarily act on the same toes entirely. Brevis goes to medial 4 and longus goes to lateral 4. Because of that variation, the slip that goes to the hallux is sometimes called extensor hallucis brevis because of that concept. Extensor hallucis brevis. But generally, people consider one of the muscles. It's just one muscle, extensor digitorum brevis. Anyway, so that was just an off the grid. Remember, that is on the dorsum of the foot, not necessarily on the leg. But it's important to talk about dorsum of the foot when we talk about anterior leg so that we understand things in totality. This image also captures for you those tendons. I put this up intentionally so that I can teach you something important about how these structures cross the anterior ankle. So when these tendons cross the anterior ankle, there's a particular order in which they occupy, a bit different from how they originate. And so this applies only to as they cross the ankle joint from the leg to the foot. A common mnemonic we use is Tom has a very nice dog pet. T for tibialis anterior. I told you this muscle causes inversion and dorsiflexion. Extensor hallucis longus causing dorsiflexion and extension of the big toe. So very nice refers to artery, vein, and nerve. The artery here is anterior tibial artery that becomes dorsalis pedis artery, the one labeled pointed with the green pointer there. Very refers to vein. Now, important to mention is that the veins at this level, the veins below the knee joint, usually run with the artery as vena comitante. So there'll be just vena comitante around the artery. And we talked about the concept vena comitante before. So I am sure you're familiar with this concept. 2 veins running side by side to an artery. Nice, the end there refers to a nerve. So the nerve there will be the deep peroneal nerve. Remember, the deep peroneal nerve will come like this and will go. It will supply the extensor digitorum brevis and then gives you a cutaneous branch that supplies the skin over this region. So that's the point that we test for the cutaneous distribution of the deep peroneal nerve. Then D for extensor digitorum longus. So this one extends the lateral 4 toes and also causes dorsiflexion. And P refers to peroneus tertius. This is better. Peroneus tertius causes dorsiflexion as well as eversion of the foot. Great. So those are the anterior, the contents of the anterior osteofascial compartment of the leg. let's look at the lateral osteofascial compartment of the leg. So the lateral compartment of the leg is this one here. Lies lateral to the fibula as well as lateral to the anterior intermuscular septum. The lateral compartment of the leg is also known as the peroneal compartment of the leg. It contains the superficial peroneal nerve, which is a terminal branch of the common peroneal nerve, running within this zone there actually. Superficial peroneal nerve supplies these two muscles, and then the nerve becomes cutaneous, as I already mentioned earlier, supplying the skin of the top dorsum of the foot. So that is sensory distribution. Two muscles, we have the peroneus longus and the peroneus brevis. So peroneus longus is the one that is more superficial. Peroneus brevis is deeper there. In this image, we can see the mass of the peroneal compartment. So this long tendon here will be for the peroneus longus tendon, and the one deep to it. So this and these are different, by the way. So this tendon is for this muscle here. And then this muscle has its tendon deep to this tendon. You see it better at this level. So that tendon and that tendon. In this image, you can see the two tendons. So you have the peroneus brevis tendon and the peroneus longus tendon. Those two muscles are the ones on the lateral compartment. These two muscles are also anchored by the peroneal retinaculum to prevent bowstring around this region. The peroneal retinaculum, however, is not as well developed as the other two retinaculum. These muscles cause eversion of the foot together with the peroneus tertius, but these two also cause plantar flexion. Remember, peroneus tertius causes dorsiflexion, but these two cause plantar flexion. So the muscle of the peroneal compartment cause eversion and plantar flexion. Peroneus tertius is not in the peroneal compartment, but it is also an evert of the foot, just like the muscle of the peroneal compartment. In terms of insertion, important to take note that peroneus longus actually crosses the foot. The tendon of peroneus longus crosses the foot, and in as much as it's entering from this aspect, it will cross all the way to insert onto the base of the first metatarsal bone. So it will cross all the way there. And that's an important factor in maintaining a transverse arc of the foot. We'll discuss that when we reach the foot. The peroneus brevis inserts onto the base of the fifth metatarsal bone, just like the peroneus tertius. So this image shows you the peroneus tertius, peroneus brevis, and peroneus longus tendon. This other image shows you the superficial peroneal nerve after piercing the deep fascia of the lateral compartment. The nerve becomes cutaneous and supplies the skin over the dorsum of the foot. Remember, on the lateral aspect will be serial nerve, and on the middle aspect will be the saphenous nerve. And then here, the peroneal nerve. We can now talk about the posterior leg compartment. Having mentioned that the posterior leg compartment has two zones, the superficial part and the deep part. The superficial part has the triceps surae muscle. So the triceps surae muscle are the gastrocnemius and the soleus. So we have the soleus, is a very big muscle here. And we have the gastrocnemia, two bellies here, the lateral belly and the medial belly of gastrocnemius. Plantaris is also a muscle that is inconsistent, and it's also usually found in the superficial compartment as well. So the triceps all insert through this common tendon here, which we call Achilles tendon or calcaneal tendon, to the calcaneal tuberosity. Important to mention some things about the triceps. So one is based on the blood supply to the gastrocnemius. So gastrocnemius receives most of the time single pedicles of arteries that enter them at that point and at that point. These single pedicles of arteries that supply the gastrocnemius make the gastrocnemius therefore be considered to be supplied by what we call an end artery pattern of blood supply. What does that mean? It means that the gastrocnemius receive blood supply from a single dominant artery, and we do not have other sources that contribute to anastomosis to supply the muscle. Which means that if this single dominant artery is damaged, blocked, or whatever, then there's a high chance that the muscle is going to undergo a vascular necrosis. And that's something clinical about gastrocnemius that you need to remember. So their end artery pattern of blood supply make them prone to a vascular necrosis. Soleus has a different story in terms of blood supply because it has multiple attachments, so it's well vascularized. Now for veins, important to mention for the three of them, the two bellies of gastrocnemius and soleus as well, is that within these muscles, we have some dilated capillaries within these muscles, which we call sinusoids. Because of the presence of sinusoids, dilated capillaries within these three muscles, the two bellies of gastrocnemius and the soleus, and especially the soleus, it means that these muscles hold or can hold some volumes of blood. Therefore, when these muscles contract, they're able to push this volume of blood they're holding in the context of the presence of unidirectional valves. This blood will be pushed up. And so this is important in promoting venous return from the lower limb. So this is also clinical to remember that the soleus especially is very important in promoting venous return from the lower limb because of the fact that it can pump blood. It can pump blood because the veins and capillaries within it are dilated. So when the muscle contracts, it will push some large volume of blood upwards. So we usually call that soleal pump or a peripheral heart, basically, promoting venous return. This is why if you are perhaps standing for long or like to stand for long, you're encouraged to contract your muscles continuously or every other often, because this will help in venous return. So what we usually do is that we're actually activating the soleal pump to promote venous return. Now, related to tendon Achilles, I want to mention something clinical. But first, let me tell you how tendon Achilles receives this blood supply. So the tendon is very thick, and it receives its blood supply predominantly from its attachments. It is attached both proximally as well as distally. The proximal attachment is through the triceps. The distal attachment is to the bone calcaneus. So the nutrients that go to the bone will either come from below, upwards, from calcaneus that is, or from the muscle attachment downwards. Look at that as some two streams of blood coming, one from here and another from below. It means that the points of attachments are well vascularized, but there's a zone that is watershed. The watershed zone is around the middle third of that tendon. This watershed zone does not have adequate blood supply. The blood supply is precarious. And the implication is this, that injury that involves the middle third of the tendon will therefore take a long time to heal because of the poor blood supply, compared to the injuries that involve the proximal or the very distal part of that tendon that will heal faster because of good blood supply, therefore good nutrient supply. So we usually say that tendon Achilles has a watershed pattern of blood supply. The term is not very important, but the concept is what is important, that there are two streams of nutrients coming in from the attachment. Therefore, the middle third is not quite receiving this good because get this nutrition because the two streams do not quite are not quite massive. So there's a region that is deficient. Now, let's talk about the deep parts of the posterior compartment. The deep compartment of the posterior leg compartment houses the long flexor tendons. And for this reason, we usually call the posterior compartment of the leg the flexor compartment. The triceps themselves cause plantar flexion because this tendon inserts into the calcaneal tendon, cause plantar flexion. You'll, however, remember that gastrocnemius cross the knee joint, so they also cause knee flexion. The soleus does not cross the knee joint, so it doesn't cause knee flexion, but gastrocnemius do cause knee flexion because they cross the joint. Plantaris also closes the joint, so it can also cause knee flexion. It's a very tiny muscle, as you can see there, very tiny muscle and inconsistent. So we usually don't talk much about it. It can actually be confused with a nerve because of that long, slender tendon. And so some people even call it freshman's nerve. Freshmen are likely to call it a nerve if you're not familiar with it. The freshmen here would refer to people who are new in the studying of anatomy, for example, can easily call it a nerve. Anyway, the deep compartment of the leg, those muscles cause flexion of the toes, and for that reason, we call this posterior compartment the flexor compartment. So these long flexor tendons, which ones are they? We have the flexor hallucis longus. We also have the flexor digitorum longus. But in addition, we also have tibialis posterior. And we have the popliteus muscle as well. We had talked about popliteus muscle when we discussed the knee joint, so I'll not talk much about it here. But in addition to those muscles, we also have the posterior tibial vessels and the tibial nerve. The posterior tibial vessels are the continuation of the popliteal artery beyond the popliteal fossa. Basically, after the bifurcation, we have posterior tibial artery and anterior tibial. The posterior tibial artery gives several branches in the posterior leg. One of the biggest branches is the peroneal artery, but the peroneal artery is also still in the deep compartment of the posterior leg, not peroneal compartment. Take note of that. We have the peroneal vessels. I've already mentioned that one. Some of these structures which are found in the deep part of the posterior compartment go to the foot, and now these ones will go to the sole of the foot. How will they get to the sole of the foot? By passing through another tunnel. This tunnel is called the tarsal tunnel. Something almost similar to what we call carpal tunnel in the upper limb, but now this is tarsal tunnel. I'll talk about tarsal tunnel shortly. Okay, so these are the images of the muscles in the posterior compartment. So this shows you the two bellies of gastrocnemius, soleus muscle. They insert through the Achilles tendon. I've already told you the pattern blood supply to gastrocnemius and artery pattern make them prone to avascular necrosis. I've also told the pattern venous drainage of the two, sinusoidal pattern, and this function as a peripheral heart, being able to pump quite volumes of blood back to the heart. And I've told you about the pattern blood supply to tendon Achilles watershed pattern, making the middle third be prone to avascular necrosis, or rather being prone to delayed injury if it's injured. This shows you soleus muscle, a very big muscle in the posterior calf. It does not cross the knee joint, unlike the gastrocnemius that cross the knee joint. So soleus does not act on the knee, but gastrocnemius will flex the knee. But however, all the three will flex, or rather cause plantar flexion. The plantaris muscle is that one. Weismann's nerve, you can see the slender tendon there, can be confused the nerve. After removing soleus, so we see the deep structures there. The posterior tibial vessels and tibial nerve are just deep there. Just deep to soleus. So they usually enter deep to soleus at this point. And so after removing soleus, you'll see them deep to soleus. And that's why you're seeing them at this particular point. As the deep structures cross the ankle, they'll be anchored by the flexor retinaculum. This is the flexor retinaculum. And so we'll have some tendons there that anchor them around this region that we call the tarsal tunnel. And these are the tendons. So the tendon of tibialis posterior. This is the flexor digitorum longus tendon. And this is the flexor hallucis longus tendon. So this is tibial nerve with its branches. And we can see the vessel somewhere there. Great. So this is the region of the tarsal tunnel. I'll give you a good talk of the tarsal tunnel shortly when we're discussing tibial nerve. Great. Now let's talk about the neurovascular structures in the leg as we finish. I'll start with the common peroneal nerve. So this is the knee region, that's the patella. This is the tibial tuberosity. So the head of fibula is somewhere here, and this is the nerve we are calling peroneal nerve. We can see it winding around the head and neck of fibula. Common peroneal nerve is one of the terminal branches of the sciatic nerve. We know that already. It can be given anywhere, but usually by the time we're in the popliteal fossa, it's already separated from the tibial nerve. It terminates via two branches almost immediately beyond this point into deep and superficial peroneal. So the deep peroneal will go to the anterior compartment, and superficial peroneal will go to the lateral compartment of the leg. This shows you the deep peroneal nerve in the anterior compartment of the leg. It will supply the musculature within the anterior compartment, and it will cross to also supply the extensor digitorum brevis before it terminates at the first interdigital web space. And this shows you the nerve as it pierces there. So it is piercing at this point. Don't confuse with this big one. Piercing this point to supply that skin there. Superficial peroneal nerve, on the other hand, is this particular big one that supplies the skin of the larger dorsum of the foot. Remember, it pierces at some point there. Superficial peroneal nerve is a nerve of the peroneal compartment. So it will supply the mass, the peroneal compartment, peroneus longus and peroneus brevis. So something clinical about the common peroneal nerve is the fact that the common site of injury is the fibula, head and neck. If you injure the common peroneal nerve at that point, then you're likely to cause paralysis of the anterior and lateral compartment of the leg. That will manifest with the loss of dorsiflexion as well as loss of eversion. We call this foot drop. People with foot drop will want to walk with their foot high up so that they do not drag the toes on the ground. So people with foot drop will have a high steppage gait as they walk. So kind of they just slap their plantar aspect on the ground as they walk because the foot is in constant unopposed plantar flexion. For deep peroneal nerve, important to note that you can also test its cutaneous distribution by checking the sensation over that point. That becomes important if you want to determine the presence of anterior compartment syndrome. So this is the point where you check paresthesia. Tibial nerve is a continuation of the sciatic nerve or the major branch of the sciatic nerve or the medial branch of the sciatic nerve. So within the popliteal fossa, we already have the nerve. It continues into the posterior leg together the posterior tibial vessels. Usually the nerve will run in the deep compartment and terminate around this region here, the posterior medial ankle. So this is the region we are called the tarsal tunnel. It terminates by dividing into the medial plantar nerve and the lateral plantar nerve. So the termination around that point. This is the medial malleolus, that is the tuberosity of calcaneus. Maybe at this point we can talk about that tarsal tunnel. So tarsal tunnel is a fibro-osseous canal located on the medial side of the ankle region. So it's a fibro-osseous canal in the medial aspect of the ankle. This fibro-osseous canal is formed by the lacinate ligament. The lacinate ligament is the flexor retinaculum of the ankle. So that's the lacinate ligament. This is the flexor retinaculum of the ankle. Partly it's been removed here so that you can see the deep structures, but yes, this is the flexor retinaculum. So the flexor retinaculum attaches to the medial malleolus anteriorly or anterosuperiorly, and also the tubercle of calcaneus posterior inferiorly. That is the flexor retinaculum. The other boundaries, so basically what would be medial and superior, will be bony. The bones we are talking about here are medial malleolus, so that would be more on the roof of the tarsal tunnel. And then we have the talus, we have calcaneus, the body of calcaneus, together the sustentaculum tali of calcaneus. Sustentaculum tali of calcaneus is a medial projection of calcaneus bone, better seen on the bone than on this particular image. And then lower down here, we have the tubercle of calcaneus. So basically we have calcaneus, talus, and medial malleolus of the tibia, forming the medial or superior bony boundary of the tunnel. This is the flexor retinaculum or the laciniate ligament that form the superficial boundary. Superficial boundary, as you can see, is also the medial boundary. What are the contents? So the contents of the tarsal tunnel are basically the structures that are found in the deep compartment of the posterior leg. Not all the structures though, but most of them. Now, this was a mnemonic for remembering them. Most people use Tom, Dick, and very nervous Harry. Tom, Dick, and very nervous Harry. Some people say teach doctors anatomy very near hospital, whichever you like. Tom, Dick, and very nervous Harry. Teach doctors anatomy very near hospital. Whatever works. The concept is, so T is the tibialis anterior tendon. So this is the order of structures from anterior to posterior, which is also from medial to lateral. So the most anterior is basically the most medial, and the most posterior is the most lateral. T for tibialis posterior. Tibialis posterior muscle, its tendon arises from the tibia, but its tendon is here. Okay, so let me say that again. Tibialis posterior muscle arises from both tibia, fibula, as well as the interosseous membrane intervening. So it's more of an intermediate muscle. But when we come at the level of the ankle, its tendon is the most anterior. Important to highlight that because we can see the crossing here with another tendon. So this tendon arises from tibia. There's another one that arises from fibula, but this muscle arises from both bones and the intervening interosseous membrane. But at the level of the ankle, the tendon is the most anterior, the tarsal tunnel. Tibialis anterior tendon inserts into almost all the tarsal bones except talus. Usually talus does not have any muscular attachment, and that also makes it have poor blood supply. We'll talk about that when we talk about ankle and foot. This tendon causes inversion of the foot as well as plantar flexion. It's a very important tendon in maintaining what we call the medial longitudinal arc of the foot. D for flexor digitorum longus. So flexor digitorum longus inserts onto the toes, and so it flexes the toes as well as causing plantar flexion. R for artery and V for vein. So these are the posterior tibial vessels. Remember, the vein form a vena comitante. Then N for tibial nerve. At this point, the tibial nerve divides into medial and lateral plantar nerves. We can see the medial plantar nerve labeled 1 there, and lateral plantar nerve labeled 2 there. H for the flexor hallucis, not so well visualized in this one, but somewhere there. I'd already shown you flexor hallucis. So flexor hallucis longus arises from the fibula, and it will insert onto the big toe. So again, the tendon of digitorum and the tendon of hallucis will actually crisscross in the foot, because remember, digitorum is arising from tibia, which is medial, but it inserts onto the lateral foretoes. Hallucis arises from fibula, which is lateral, but it inserts onto the big toe, which is medial. In particular, the tendon of hallucis, flexor hallucis longus, is very key in also maintain the medial longitudinal arc of the foot. We usually consider even that as another function of that tendon because the tendon is well aligned with that particular arc. So it acts like the string of a bow in maintaining the medial longitudinal arc of the foot. So this image perhaps captures all that I've said. The tendon of tibialis posterior, the tendon of flexor digitorum longus. Then we have the posterior tibial neurovasculature, where we have the artery and vena comitante, that's posterior tibial. And then we have the tibial nerve and its two terminal branches. And then the flexor hallucis longus tendon. How is the tarsal tunnel clinically important? Tarsal tunnel is clinically important because of what we call tarsal tunnel syndrome. A tarsal tunnel syndrome is the symptomatology that arises following compression of the neurovascular structures within the tarsal tunnel, but in particular, compression of the tibial nerve within the tarsal tunnel. So again, similar concept is that the tarsal tunnel is non-yielding, so it can, if there's pressure there, it can compress the nerve. So the symptom that will arise because of that is what we call tarsal tunnel syndrome. I can leave it to you to figure out then what this symptomatology actually entail. As you can see, so that's the flexor retinaculum and this is the nerve. So its compression within here will constitute tarsal tunnel syndrome. Let's talk about the deep vasculature of the leg. We've already talked about the superficial veins when we started. So the deep vasculature of the leg, we have the popliteal artery, which came down. Popliteal artery divide into two, posterior tibial and anterior tibial artery. Anterior tibial goes into the anterior compartment of the leg, passing above the gap, through the gap above the interosseous membrane to become anterior. So it runs in the anterior compartment, as already mentioned, supplying the mass to the anterior compartment, as you can see here, then crosses the ankle to become the dorsalis pedis artery. So as clinical, we can pick the pulsation of the anterior tibial artery at this point. At the midpoint between the medial and lateral malleolus, we call that the mid-malleolar point. You can consider that as the anterior tibial pulse or the dorsalis pedis pulse because they're continuum. However, for the dorsalis pedis, you can still feel it all the way until where it disappears at the proximal part of the first, the gap between the first and the second metatarsal bone. So the first intermetatarsal gap, that's where the artery disappears to go to the plantar side, of course, supplying other things before it disappears. The branches that these arteries give us around this point will constitute what we call the ankle joint anastomosis. So anterior tibial artery will give you some branches, which we call the malleolar branches. Dorsalis pedis will also give us some tarsal branches that will still constitute part of the ankle anastomosis. Remember, if there is compression of the anterior tibial artery, you check the pulse down here. So if there's pulselessness, then you know that there's some compression of the anterior tibial artery. The posterior tibial artery continues in the posterior compartment. It gives you a big branch, which you call the peroneal artery, that goes immediately behind fibula. Peroneal artery will supply the muscles of the peroneal compartment, but through branches. The main artery is actually in the posterior compartment, but its branches are the one that go to supply the peroneal muscle. So it's supplied through perforating branches, basically. It's also a very important artery in the leg because it applies a number of deep structures. The posterior tibial artery itself will run together with the tibial nerve and they disappear at the tarsal tunnel, where now the posterior tibial will divide into medial and lateral plantar arteries at the tarsal tunnel, just like the tibial nerve also divides into medial and lateral plantar nerve. It will be remembered that peroneal artery may terminate by becoming anterior, going through some gap between tibia and fibula down there to become anterior, and so sometimes supporting the territory of the dorsalis pedis artery. The veins that accompany the arteries have similar names, and they form vena comitante. Something important to note about the veins of the lower limb is the fact that they are prone to what you call deep venous thrombosis. So what is deep venous thrombosis? So this is basically clotting of blood within the deep veins. The blood within the lower limb is prone to clotting because the blood in the lower limb has to fight against gravity to go back to the heart. So because of that, stasis, the venous stasis of the lower limb make that blood be more prone to clotting. For this reason, we usually encourage patients even to become as ambulant as possible, soon as possible, so that they do not stay so long in the bedridden, because being bedridden will mean that there is a lot of stasis. You are not using your muscles to pump blood back to the heart. You remember what I told you about soleus and gastrocnemius helping to pump blood. So if you're not active, the venous stasis is promoted, and so the blood tends to clot. What's the danger of having deep venous thrombosis? One, of course, is that it's a very painful thing, usually manifested by unilateral leg swelling and pain, as you can see in this particular patient. Most of the time it will be unilateral. But other than that, this clot that has formed can actually dislodge. And if it dislodges, it will now be running within the vascular system. And remember, the veins, as you go back to the heart, become wider and wider and wider, which means that this clot will actually find it easy to just run like that very easily. This clot will now be called an embolus when it's now being propagated. Now, thromboembolism means that the clot, the thrombus, is now running thromboembolism. When you have thromboembolism from the lower limb, this clot will go all the way to the heart because the vessels are wide and wide and wide until you reach the heart. Then when you got the right chambers of the heart, right atrium, then right ventricle pump it to the lungs. Now, from the heart to the lungs, the vessels become narrower and narrower as you go towards capillaries. That's where the problem is. This clot will get stuck within the pulmonary arterial tree. And so we call that pulmonary thromboembolism, one of the medical emergencies that we will ever come across. If for some reason a patient has a congenital heart disease where there's a hole in the heart from the right chambers to the left chambers, let's say from the right atrium to the left atrium, that is making blood to move from the right atrium to the left atrium. Usually, such holes will allow only blood from the left to the right. But in case, for some reason, that in this particular patient, blood is moving from the right to the left, then that thrombus can actually also just be thrown to any part of the body, and it can give you something like stroke. But those are very rare circumstances. It must be the context of a congenital heart disease that allows some right to left shunting of blood. In most common circumstances, this thrombus will be dislodged in the lungs. causing pulmonary thromboembolism over 90% of the time. Great. So that brings us to the end of that lecture session on topographic anatomy of the leg. I hope that you grasp something that you now know about the leg. Our next session on topographic anatomy of the lower limb will be on the ankle and other joints of the foot. Thank you very much. We'll stop there.